Hello and welcome to the Boston Structural Heart course. In this How I Do It series, we are going to go over the comprehensive transesophageal echocardiographic examination and also on the conduct and its workflow, but more specifically, we are going to go over the sequence of image acquisition and interpretation. These are my disclosures. I make educational materials for Abbott Medical Systems as well as GE Ultrasound. Now, the first question to answer is that what led to this presentation? Well, of course, this was a case that we had recently at our medical center, very educational, and something that led me to make this presentation for everyone. Now, this is actually a nightmare scenario. This is a young patient who had a stroke a year after had his coronary artery bypass graft surgery. I was the anesthesiologist in the case, but his rule-out source of embolism, transthoracic echo, demonstrated a patent foramen valley, and we were all asked to look at the intraoperative transesophageal echo to see whether we had missed a patent foramen valley, and did we really look at it? Did we miss it? And if we did not, then why didn't we fix that patent foramen valley at that time? So that was the deal, Now, quite honestly, I did not remember. There's so many things happening in the operating room at that time that you really don't have any idea of what specific view you looked at, or if you looked at, did you store it, and what it was like. So this was the real nightmare scenario, and I realized that a lot of people at this time we're doing things quite randomly rather than in an organized fashion. Rather than having an exam that I've done in a very routine fashion, which involves looking at every possible image and storing it, the sequence of examination that I practiced and that everyone else practiced was quite random. And as it says is that the threshold of examination should be that if I did this a T examination, I looked at it and I stored the image that was and for any specific intracardiac structure. Now that should be the threshold, because if you're asked about a certain specific diagnosis 20 years after you did the examination, you should be able to say with a reasonable degree of confidence that if I did it, then I looked at it. Now the key over here is that American Society of Echocardiography has come out with some fabulous guidelines that relate from chamber quantification to systolic function, diastolic function, strain analysis and speckle tracking, and a lot of other cool stuff that we can do in the operating room. But in reality, when you're doing an intraoperative or outside the operating transesophageal echocardiographic examination, you have just about 15 or 20 minutes to actually do a comprehensive exam, and then kind of boil all these 15 or 20 guidelines into about a 20-minute examination and not missing anything relevant. Now that's the art that you learn with experience, and that's the thing that you should strive for. And what I call it is organizing the guidelines into a comprehensive exam, or essentially putting everything together. Now the components of a comprehensive exam can be looked at in multiple fashions. It could be qualitative, quantitative, it has to be comprehensive, and also focus sometimes to answer a specific question. Now when you look at a heart, you have to look for different things. You look at chambers, that's the great vessels, the right left atrium and right and left ventricle, the septa that separate them, the valves and the vessels. So a lot of things to look for it structurally and functionally. It's always a question that bothers a lot of fellows. So where do I start? What is the sequence and go from one examination to another? And what is the bare minimum information or the maximum information that I can provide and that I should look for? And also now with an added benefit, or also an added problem of having three-dimensional imaging probes, when and what should I do the 3D TE for? So these are all good questions. Now the good thing is that on our YouTube channel, Boston Structural Heart, we have addressed the comprehensive transesophageal echocardiographic examination in a very, very literally and figuratively comprehensive fashion. We have about 3 hours of presentation that follows from what the prerequisites are, what the conduct is, and how do you interpret it. And I strongly encourage you to follow this link to go to the comprehensive exam lectures and the Boston Structural Heart YouTube channel. So the purpose of this presentation is not to rehash or reinvent the wheel as far as that is concerned. Now, let's see how I do an exam, because this relates to how I put all that knowledge and information regarding a comprehensive intraoperative exam into an actual case. Now, this is a 67-year-old male. He had an acute MI. He was on an intra-aortic balloon pump on heparin and nitroglycerin infusions, was admitted overnight for a rather urgent CABG in the morning. They just wanted to stabilize him and get it started with. Now, this exam essentially had a bit of everything. A bit of urgency, an anticipated finding that you'll eventually see in the exam, A general and focused exam had to be done, multiple calls to be made regarding the diagnosis and monitoring this patient or what to do with this one. Now, how I do it involves a sequence of 2D images, 3D imaging, Doppler interrogation, both pulse, color wave, continuous wave as color flow Doppler information, and lastly, quantitative information as far as structure and function is concerned. Now, there are two approaches to an examination, and they are basically based on this one simple factor, and that is there a specific clinical question to answer. Now, you could do a comprehensive exam and then go to a focus exam to answer a question, or you could do a focus exam initially, answer the specific clinical query, and then go on to do a comprehensive exam. My specific preference is always to do a comprehensive exam and then go on to do a focus exam. Now, that's with a good reason for it. And that's because comprehensive followed by a focus exam, the advantage of this approach is the availability of context of the information. It helps you interpret the focus examination, putting all the findings in perspective so you can give a more educated response, a most educated guess, and a much more informed recommendation regarding the surgical approach. So now let's get started on this, how I do it. Step one of this focused and comprehensive exam, the sequence of this one, is to get the logistics right. This is again something that I'm borrowing from our comprehensive intraoperative TE examination lecture. And that's first thing is get the logistics right. So choose and know your system well. A knowledge of the equipment that you're going to be operating is the first and the foremost thing in getting this exam sequence right. You should know how to operate that equipment. Step two of this exam is to enter the accurate DICOM information. That includes the last name, the gender, the first name, date of birth, height, procedure, operator, and finally is the performed by. These are a few of the most important things. For example, looking at the DICOM headers, an Philips machine, this is the patient's name, this is the medical record number, two of the most important things, the date, the time, the type of probe, and lastly, the operator. These are the things that you need to put them on the examination, because these are DICOM headers, and you got to be very careful that the information that you're putting in this one is pretty accurate, specifically the medical record number as well as the patient name on this examination. We also tend to put the name of the operator also, so we can trace back who did that, as well as the date of the operation. Step three in this sequence is to concentrate on the whole image and not just the information that is being presented by this inverted pie over here. For example, looking at these important informations, this shows the institution, this shows the probe, the frame rate, the depth, and the 2D exam settings. This specifically shows the settings of the machine, for example, and this demonstrates that we are using harmonics. We are in general imaging mode, optimized for both penetration as well as resolution, and we are looking at the middle range of the frequency, and this shows the patient exposure to ultrasound. So these are the few of the most important things to look at before you start the examination. And that implies that some of the most important information that determines the quality of the examination is essentially outside the scan plane. So you have to look at it, and sometimes simply looking at the scan plane settings, you can be pretty certain how experienced or novice the operator was. The next step in this direction is to understand that there are 4 probe positions and 4 scan plane rotations. The 4 probe positions are upper esophagus, mid esophagus, and there are 2 transgastric positions. Then the scan plane rotations are at a horizontal axis, that is 0 degrees, a vertical axis, that is 90 degrees, and 2 oblique axes, that's 45 and 135. So therefore, and the entire sequence examination is a combination of probe position with scan plane rotation. For example, in the upper esophagus, we look at the ascending aorta, the main pulmonary artery, the right main pulmonary artery, the distal aortic arch, as well as the proximal descending aorta looked at over here. And we'll go over each one of these positions in about a short time. In the mid-esophagus, we assess mostly the contractility of both left and right ventricle, look at regional wall motion abnormalities, left and right ventricular size. We do diastolic function assessment using E over A, E over E prime, left atrial size, and left ventricular outflow tract diameter for cardiac output. Going further down into the stomach, we look at the wall thickness that determined by, and wall motion determined by the adequacy or the lack of it of blood supply to each specific wall, chamber size, diameter, wall motions, and lastly, cardiac output in this location. And step 5 is essential to put it all together. So my sequence of examination starts in the mid-esophagus, then I move to the upper esophagus, and then I go to the transgastric position. And at each location, I use 2D, 3D, color flow Doppler, both pulse wave and continuous wave, do a systolic function assessment, and lastly, a diastolic function assessment as well. So this is where I start. This is 0 degrees, mid-esophageal four-chamber, look at the septum, the right atrium, left atrium, right ventricle, and the left ventricle, tricuspid and the mitral valve, and I'm looking at the portion of the coronary sinus over here. Next, we rotate to 45 degrees to get one of the most important views, and that's the transcommissural view, where you look at the P3, A2, and P1 segments. That's my next rotation. Next, keeping it in the mid-esophagus, I rotate to 90 degrees when you look at the anterior and the inferior wall, and next I rotate to about 120 to 135 degrees to get the mid-esophageal long axis view. Now this is one of the most important views because a lot of things that I do over here determine how I do the exam. You're looking at the right ventricle here, the aortic valve, the mitral valve, left atrium, left ventricle, LVOT, the aortic root, sinuses of Valsalva, sinotubular junction, and the proximal ascending aorta. Things that you can do based on the wall motion assessment, you're looking at the anteroseptal wall over here, which means you're looking at the infolateral wall over here, and this is one of the views that we can look at both these walls. At the same time, we are also doing the anterior septum, infralateral wall, the aortic valve, and the right ventricle, and we can do a lot of other quantitative assessment, which means the AP diameter of the mitral valve, the LVOT diameter, which can be plugged in to measure the stroke volume and cardiac output, the sinotubular junction, and as well as the sinuses of Valsalva are measured over here. This is what we do in real life. This is the aortic annulus, the sinuses of Valsalva, and the sinotubular junction. At this location, we also put in color flow Doppler to look at both mitral and the aortic valve. In this specific patient, the unanticipated finding was the presence of aortic regurgitation, which was not known preoperatively. So that was an unanticipated finding. So now what I prefer to do is to quantify these things as I go along, because I don't want to come back and waste time on quantification of something, that question that may be answering. For example, in the mid-esophageal long axis view, I will measure the vena contracta as well as use color flow and M mode to measure the jet width in relation to the LVOT diameter. So therefore, I'm kind of making my mind up as relates to the severity of mitral aortic regurgitation in this patient. Next view, I slightly turn the probe to the right to look at the kind of modified bicaval, left atrium, right atrium, intraatrial septum, the fossa ovalis, and the right upper pulmonary vein to demonstrate both right and upper and lower pulmonary veins entering into the right atrium to ensure that all the plumbing is in the right place. While I'm doing this thing, I'm also putting in pulse wave Doppler in the right upper pulmonary vein to get the S and D waves as well as the atrial reversal wave. So that's kind of a start of my diastolic function. I do not make any measurements or analysis at this time, but I keep acquiring the images just in that odd case that I do not have the ability to come back. I also bring the scan plane to 90 degrees and kind of interrogate the fossa ovalis as well as the IVC, SVC, and the intraatrial septum as a whole a little bit more comprehensively. And that involves adjusting the scale appropriately, looking at for a patent foramina valley, just like the case that we had, and to have the box location more appropriately. And sometimes, if I really have a strong index of suspicion, I could do a Valsalva maneuver with or without contrast in these patients. Next, keeping the probe in the neutral position, I rotate to between 50 and 70 degrees to look at the RV inflow and outflow view. This is the right atrium, the tricuspid valve, the right ventricle, RVOT, the aortic valve, intraatrial septum, and the left atrium. And you're just looking at the proximal main pulmonary artery in this view as well. Now, at this location, remember that your The last color flow Doppler color flow Doppler interrogation was done at a Nyquist limit about 22 centimeters per second. So adjust it appropriately to quantify tricuspid regurgitation. Look at the aortic valve, and again look at the regurgitation, not only the width of the jet but also its location. Like in this specific case, it seems to be coming from between the center of all the three cusps as well as at the base of the non and the left coronary cusp. So now comes the value of getting 3D imaging. So the main important thing is one of the review articles that we wrote about the practical approach to transesophageal echoes, published in I think a long time ago in 2016, where we said that as opposed to two-dimensional imaging, three-dimensional imaging provides supplementary data and not necessarily the main primary data to make a certain diagnosis. So a comprehensive intraoperative 3D examination is used for acquiring and archiving supplementary 3D echocardiogram data for real-time and post-acquisition qualitative and quantitative analysis. So my best, there's no good time to acquire these images, but my recommendation is to acquire them as you go along. So for example, get them as you go along is the motto. For example, specifically in this patient, we needed to get a 3D of the aortic valve with and without color flow Doppler to specifically look at the vena contracta and accurately identify its width in relation to the narrowest portion of the jet, and we can do that for a later MPR collection. And again, we go back to the second look at the intra-atrial septum, looking at the anterior rim of the intra-atrial septum to exclude a patent foramina valley, and again, appropriate adjustment of the Nyquist limit, as you can see in this one. Now we come back to our midesophageal window again to look at the ventricle in four chambers: right atrium, right ventricle, left atrium, left ventricle, and now we could go do the remaining sweep. For example, slight anti-flexion of the probe at 0 degrees. You can visualize the both left upper and lower pulmonary veins, the coumadin ridge, as well as the left atrial appendage. I again use the pulse wave Doppler in the left upper pulmonary vein to look at the S and D waves, atrial reversal wave, and also measure the left atrial ejection velocity that has important diagnostic information in relation to the risk of forming clots. At this point, I also put the pulse wave Doppler at the tips of the mitral leaflets, get the E, A wave, and measure the E wave velocity, the D cell time, as well as the E over A ratio. While it is still there, using the tissue Doppler, I put it in the lateral mitral annulus and get the E prime velocity, and our machines are geared to provide us the E over E prime ratio, which is 6.19, pretty much within normal range. So this patient seems like his normal systolic function as well as normal left ventricular and diastolic pressure. So in this patient, I could look at the midesophageal long axis view and realize that it was only mild MR, so I'm not wasting too much time and using the triplane or simultaneous orthogonal plane imaging function of this machine, looking at the midesophageal four-chamber, transcommissural, and the midesophageal long axis view at the same time to knock out the diagnosis of mitral regurgitation of being mild at best and not waste too much time on it. I would not, hesitate to get a three-dimensional image of the mitral valve. This is an en-face view, and store this raw data. Now, the key part is storing this raw data, that is the volumetric three-dimensional data. It gives you the opportunity to go back later on into a quantification software and do a clinical, research or any other quantification of the mitral valve that you can do later on while you're done with the exam and you're not being pressed to answer specific clinical questions. At the same time, I can also look at the tricuspid valve, that is the midesophageal four-chamber view, in this view, the RV inflow view, and measure the RV as well as the RV diameters as well as the tricuspid annular diameter in the septal view. And in real time, this is the tricuspid annular diameter, the RV basal diameter, RV mid diameter, as well as the RV long axis diameter, which can be measured in the midesophageal four-chamber view while you're completing this exam. I can also take this opportunity to measure TAPSE, which is again the tricuspid annular plane systolic excursion, to knock it out of the way and do a comprehensive functional as well as qualitative and quantitative structural and functional assessment of the right ventricle. Then we go on to upper esophagus at 0 degrees, look at the ascending aorta, the main pulmonary artery, the right main pulmonary artery as well as the SVC, look at it in 90 degrees, as well as 120 degrees to look at the ascending aorta, that is the proximal ascending aorta, in 3 different views, and immediate and save a lot of time. And I can always freeze and do diameter measurements, but I can always come back later on after acquiring to get these, specifically the diameter of the ascending aorta. Now, as I advance the probe into the coronary sinus, I look at the coronary sinus somewhere between the mid-esophageal four-chamber and the transgastric window to certify that it is present, or the lack of Thebesian valve, as well as the lack of dilation, to rule out a left-sided SVC. In the transgastric position, more specifically, we look at the left mid-short axis when you're looking at the papillary muscle, as well as we look at the basal short axis of the left ventricle to assess for not only the diameter, the axes, and the systolic function. We can also do triplane imaging over here, which means look at the left ventricle in 0 degrees, in 90 degrees, as well as 130 degrees. I don't know if this makes any sense or not, but more importantly, we can look at it in 0 degrees and 90 degrees to look at both the anterior and inferior walls. And sometimes you can actually better visualize the apex of the left ventricle in this specific location. We can also measure the end diastolic diameter, the wall thickness, and more recently I've become very fond of using the M mode to assess the wall, the chamber dimensions, the shortening, the wall thicknesses, and to calculate the fractional area change of the ventricle in this situation. At this point, we move into the deep transgastric window and specifically align the pulse wave Doppler parallel with the LVOT to measure not only the aortic valve area, if I have to, and the stroke volume by doing the VTI across the LVOT, and estimate the cardiac output. This is one of the most important quantifications that can be performed regarding the systolic function and the left ventricular performances, the stroke volume, and cardiac output calculation. If there's presence of AI, we can also use this as a means of measuring the pressure half-time. This is the pressure rate of decline of pressure in the proximal ascending aorta to the left ventricle, and it's being less than 220 implies that it is not only severe but acute. I don't know a pressure half-time of 300 or 400 makes any sense, because it just implies the presence of chronic AI and ventricular remodeling. Then we go on to look at the right ventricle, again in the short axis view, as well as the simultaneous orthogonal plane imaging to look at the RV inflow, as well as the anterior and posterior parts of the tricuspid valve. Lastly, we come to the position, this is something that is often forgotten in patients who have intra-aortic balloon pump, to look at the descending thoracic aorta and confirm the position of the intra-aortic balloon pump just about a centimeter below the left subclavian artery to see that it is appropriately augmenting the diastolic flow. This is often forgotten. Then we withdraw the probe further and look at the distal arch and the descending junction to quantify the presence of atheromas, which are often present in these patients. So going back to the multiplanar reformatting, now that we've gotten all the 2D color flow Doppler images, I often at this stage go back onto the 3D acquired data to measure the various diameters of the mitral valve, which involves AP diameter, ALPM diameter, the tenting height and tenting area and tenting volume. In specific reference to the aortic valve, we can also use multiplanar reformatting of the aortic valve to ideally measure the narrowest portion of the aortic regurgitation jet as well as the area of the regurgitant orifice. Well, our system also has the ability to put landmarks over here on the specific scallops of the aortic valve, so we can be very precise in our diagnosis of the retraction or prolapse of a specific scallop or the portion of a scallop which is responsible for this aortic insufficiency. You go back at this stage to measure the S, D, and atrial reversal waves to further refine the diagnosis of diastolic dysfunction, quantify the atheromas in the aortic arch, and then come up with the diagnosis. Descending aortic dimensions, never forget about them. And now as we finish this exam, you can see that we have done a comprehensive 2D examination which is both qualitative and quantitative. We use Doppler in its entirety, that is, pulse wave for filling, continuous wave to exclude stenosis, color flow Doppler to identify not only venous and structures but also quantify regurgitation. A functional assessment, that is both systolic and diastolic. Raw 3D data was acquired of all the valves, specifically mitral and aortic, that required some further elaboration of their dimensions. And finally quantified an unanticipated finding, that was the presence of aortic insufficiency, which we deemed as mild and therefore provided the basis, a quantification basis of a very important clinical decision. So at the end of the day, I didn't want to be too long, a presentation about the nuances of a comprehensive exam, but exactly the specific sequence of exam, the way I do it. And the lesson that I learned is that the threshold of each examination should be, if I did the TE exam, I looked at it, I recorded it, and I reported it. Thank you very much.